Judges, my esteemed colleagues, presenting a paper on real-world evaluation of combination therapy in acute post-cataract endophthalmitis, and we disclose nil financial interest. So whenever you hear about a post-cataract endophthalmitis management, the first concept that comes into your mind is the endophthalmitis vitrectomy study, even though it was established nearly 3 decades ago. It favored tap and inject for eyes with hand motions vision or better, and reserving the limited core vitrectomy for light perception vision. And then came the 2000 and 2010, there was everything went into micro incision. And here we stand in 2025 with emerging evidence suggests that early pars plana vitrectomy with complete vitreous clearance may improve the visual outcome in post-cataract endophthalmitis, where SEEVE study has demonstrated the clear-cut outcomes. So our aim was to assess the outcome of a combination therapy, initial tap and inject, followed by an early pars plana vitrectomy within 72 hours of disease onset, and to determine the key predictors associated with the optimal visual recovery. It was a retrospective, non-randomized, interventional consecutive case series done in a tertiary referral center at Cochin with a 3-year period duration. So acute post-cataract endophthalmitis in this study was defined as the development of clinical symptoms and signs of endophthalmitis within 6 weeks following cataract surgery. So these patients presenting with a visual acuity of light perception of better with a minimum of follow-up of 6 months was included, and pre-existing maculopathy or any prior history of vitrectomy, any other intraocular procedures were excluded. So irrespective of the initial presenting visual acuity, all the patients were given a shot of intravitreal vancomycin and a ceftazidime with aqueous and vitreous sampling. And these specimens were sent for microbiological analysis and followed by a standard 25 gauge pars plana vitrectomy. So when not pre-existing, PVD injection was induced with maximum possible peripheral vitreous clearance to remove the infectious and the inflammatory load. And whenever there was an iatrogenic break, it was managed with endolaser photocoagulation, and whenever needed, silicone oil tamponade was used. So these are the baseline demographic and the clinical characteristic, which is compared to the landmark cohorts, that is the EVS and the SEEVE study. The mean age of presentation was 68, and the mean presenting visual acuity in our study was worse than the EVS and the SEEVE study. Culture positivity rate was got in 42.1, and ceftazidime resistant organisms was got on about 3 eyes, which was not reported in any of the studies before. So coming to the visual outcomes, compared to the baseline and the post pars plana vitrectomy, there was a definite improvement in the visual outcome. About 40% got improvement in the visual acuity of 612 or more. About 80% achieving visual acuity of more than 6/18. In 10% of the eyes, there was poor outcomes. And iatrogenic retinal breaks during the surgery was observed in 3 eyes, which was successfully managed with the endolaser and silicone oil tamponade. And post-vitrectomy, retinal detachment was occurred in 2 eyes, which was also well managed. Overall reintervention was required in 5 eyes, 2 for retinal detachment and 3 for persistent inflammation. And culture positivity was obtained in 42.1 of the patients, and with a gram-positive predominance consistent with the typical patterns. But there was a ceftazidime resistant nature which was found in about 3 patients. So the major critical prognostic factor which was analyzed during a multivariate analysis was that whenever there was a complete vitrectomy with PVD induction, it showed as an independent predictor of superior final visual acuity. So this was found during the forest plot predictors as well as the Kaplan-Meier curve. Whenever there was a complete vitrectomy with PVD induction, there was a superior prediction of the visual acuity. And when there was an incomplete vitrectomy, there was poor visual outcome. So why this early complete vitrectomy works? Because all the experimental studies revealed that rather than the viable microorganisms alone, the retinal injury in endophthalmitis is predominantly mediated by the bacterial toxin as well as the inflammatory cascade. And the vitreous serves as a reservoir for this injurious factor. So the complete vitrectomy minimizes the endophthalmitis maculopathy, limit all the toxin mediated retinal damage. and why we preferred intravitreal antibiotic, then followed by early vitrectomy. So there is a sieve study that advocates straight to the pars plana vitrectomy, and there is an EVS cohort that treat the hand motion vision only with intravitreal antibiotics, better than the hand motion with intravitreal antibiotic. So we stand somewhere in between an intravitreal antibiotic followed by early and complete vitrectomy whenever possible. The first thing is that it rapidly addresses the infection, it reduces the harmful toxin, and it provides a window for the patient to prepare for the surgery. And most importantly, there are some patients, especially presenting with good visual acuity at initial presentation, these may respond only to intravitreal antibiotic. So inadvertent surgeries can be avoided. So these are some representative cases: a patient of hand movements vision, status post intravitreal antibiotic, and post vitrectomy improving good visual acuity. And these are some of the representative cases: preoperative fundus photo with vitreous haze and postoperative fundus photo with definite retinal clarity. But coming to the visual outcome, we may think the patient is having a crystal clear retinal clarity, everything is normal, but coming to the OCT, you can find some kind of toxicity has involved the macula. You can see there is disruption of the ellipsoid layer. So we definitely think the toxin mediated injury, it is responsible for some sort of vision loss even after the vitrectomy. So this lot should be cleared as early as possible. And there was an challenge in the gram negative. Our forest plot analysis showed that these gram-negative infections were significantly associated with incomplete vitreous clearance and a poor visual outcome at the end. So coming to conclusion, initial tap and inject followed by early complete PPV within 72 hours yields favorable visual outcome. And complete vitrectomy with successful PVD represent a strong prognostic factor for visual recovery. And we strongly suggest EVS guidelines require revision. So this tap and inject followed by the modern minimally invasive complete clearance of the vitreous can represent an optimal standard of care. Thank you.
I really fail to understand why you had to strategize it to see, for example, if you look at gram negatives which worsened, which did not give us a adequate result where you could not achieve vitrectomy. Had we gone as a CV study and gone initially only with vitrectomy, if you are planning vitrectomy as a must procedure in every case after about 72 hours, why not at the first step? That's what the rationale. Why was the study planned that way? Why not as a primary procedure when we are looking at it at 72 hours? Why the delay you wanted?
The first thing is that this is a retrospective study. So in the retrospective study, we took all the cases which was underwent this way, and we found out that because initially we don't know whether it is gram negative, whether it is gram positive, that is causing the endophthalmitis. So we studied with this, we came to
This
the
subset
conclusion.
was studied by you,
Yes,
not the overall cohort of whatever endophthalmitis has undergone in last few years.
yeah, exactly. This was studied and we came to a conclusion like this.
Somehow I don't know, but I feel had we gone as a primary procedure in all these cases, because we could have achieved more the toxins, more the edema, you are going to have more heterogeneity, more
Because
toxicity
there
problems.
are few patients which improve along with the intravitreal antibiotics.
So there you didn't undergo a phase.
No, no, no. That is not included in the study at
Yeah,
all.
so that is the confusion because I had the same confusion because you said your initial cohort, all of them were underwent vitrectomy. And then your conclusions, you said those which did not have, much vitreous haze, we decided to give intravenous antibiotics. So what your hypothesis to what you concluded were completely different.
No, in the inclusion criteria, I clearly mentioned that these patients who had only undergone vitrectomy was included in the study. Those which had improved with intravitreal antibiotics alone was not included in the study.
Okay, so you could have just presented it better because you should have just picked those and don't talk about, those that did not require vitrectomy. So you brought that angle in also. That's why the confusion. That's why he's also asking this. And I also agree with him. While I understand your limitations, it's a retrospective study. If you have a presentation of what looks like gram negative, why would you wait for 3 days, right? Because in 3 days, things can actually get significantly worse. You got away with good results. this could have been, significantly worse.
But the end of the day, gram negative showed poor results only. Whatever we
Yes,
got as
yes,
gram negative,
absolutely.
it has poor
Yes,
results
yes,
only.
yes. No, so that is where that logic of waiting 72 hours, will not work. So you also then, because retrospective, you also took those that were not fungal presentation.
Yes.
Because that's because you went and gave antibiotics because you picked that was